So I get to share actually 3 separate projects with you. The first one that I want to talk about is referring to our disease log project, which Mike referenced. The background of this project is that more and more trainees are seeking to go abroad. There's increasing recognition that there's significant academic, personal, and professional value in these experiences, and more and more people are looking for this as they come to training programs, myself included. If you opt into the track, as Mike said, there's a pre-departure checklist and also a post-trip checklist. The disease log has been part of our post-trip checklist, and it's essentially a list of questions that we ask trainees when they come back. What were their top 10 most impactful or interesting experiences? We've been collecting this data for a long time, and we're curious about the themes and lessons that we could learn from this data set and how that might improve our pre-departure training and also guide our experiences in general. So we created a study. For the past year, we've been collecting this data. We had a 100% response rate from the residents, and this yielded 129 unique stories representing 7 countries from our partner relationships. We completed a qualitative analysis to look at this data, and this came up with 27 codes or 9 key themes. I'm going to share a little of some of the most interesting results. Not surprisingly, about 85% of trainees talk about things like diagnostic ambiguity, severe presentations of common diseases. The importance of physical exam was a nice thing to see come through really commonly. One thing that was a little bit more surprising is that about 50% of trainees mentioned a clinical win. So sometimes our stereotype is that trainees experience lots of hard things while abroad, and I think that's true. But over half of them wanted to tell us about things that were awesome. One particular example that comes to mind is a child presented to the hospital with an organophosphate ingestion, and the team successfully intubated the patient and were able to see her through the course of her hospitalization, and they wanted to tell us how meaningful that experience was for them. One thing that was really interesting to us was 100% of trainees mentioned the encounter that they had with limited resources. So we actually did a sub-analysis of this group and wanted to see what sub-themes came through. And yes, we expect trainees to encounter limited resources, but what are lessons learned? What are they walking away with? About 25%, 23% mentioned triage or transfer. And I'll just read a quote from this resident, which we thought was really interesting. The most impactful cases were those that involved navigating the geopolitical, psychosocial, and economic issues that were barriers to our patients' ability to access care. We thought this referenced the social determinants of health in a meaningful way. Another really cool thing was that almost 40% of trainees wanted to tell us that limited resources led to advocacy or innovation. Examples of that were spacers made out of water bottles. Another resident taught a family to use chest PT with a child with SMA. Other people talked about things like making an IO with an 18-gauge needle, making a standardized checklist, and feeling really motivated by the experience, lessons that they bring back and teach us about. And I should mention that Dr. Tina Slusher teaches a lot of these skills, the spacer for the water bottle and a number of other procedural skills before trainees go abroad, which was also cool to see that some of our pre-departure training is translating into clinical care abroad. 92% of trainees mentioned limited resources and its relationship to a negative patient outcome. Things like families not being able to afford the necessary blood products, or knowing that a radiologic reduction of intussusception is standard of care in the US, but that not being an option internationally. And 50% talked about delay in diagnosis. One of the takeaways for us from this was, gosh, residents are dealing with hard stuff abroad. And it's been an interesting reflection as we think about how can we prepare them to deal with some of the concepts of moral distress or the emotional, spiritual, and mental challenges that they're facing. And 100% of residents who talked about limited resources also talked about a different clinical approach or an incomplete workup, which I think there's a lot of opportunity for learning in that. 85% even tied that to physical exam skills and empiric therapies. it became really obvious as we were looking through this data set as well that the concepts that residents talked about mapped beautifully to the ACGME core competencies. And it really echoes the previous work looking at the essays as well. Specifically, the limited resource subset mapped to all 6 core competencies. When we went back and looked at all 9 key themes, you see that all of the themes map to multiple ACGME core competencies, which again, I think makes a really nice argument for the academic value of investing in global health education. Next, I want to briefly highlight Project Prime. This is a multi-institutional project that I've had the privilege of being co-PI on with Mike Pitt. It stands for Psychosocial Response to International Medical Electives. A little bit of a mouthful, but it's a project that's looking at the experience of culture shock that trainees have. So we know that they experience culture shock, but can we predict when and how much? And the goal of this project is to be able to intervene when trainees are struggling abroad. So it's actually a predictable time course, and also hopefully decrease the harm that we may be causing when we go abroad. The way the study has worked is trainees are enrolled online and they get real-time surveys while they're abroad. So they take one before, and then every 5 days while they're abroad, they answer a set of validated questions and then answer another set when they come home. We've enrolled 29 people at the University of Minnesota, a combination of residents and medical students, and 112 nationally. The data is yet to be analyzed, but I think this will be really interesting and should be coming out in the next year. And last but certainly not least, I want to take you to Cameroon. So this is a photo of Mbingo Baptist Hospital. It's one of our partner relationships that we have. It's the only med-ped site, and we have been working for the past year and a half to develop a longitudinal relationship there, looking specifically at the question of G6pd deficiency and how it relates to infection. So the prevalence of G6pd deficiency is pretty well established. Many of our colleagues have done these studies, and that was definitely part of the project, but it's the first project really looking at infectious markers in relationship to G6pd deficiency. So we developed a really strong relationship with the lab there and did a donor blood prevalence study using blood donors that are already in practice there. This is a photo of the Butler spot method, which is how we studied the prevalence. And one of the things that has both been a lesson for me and also a really inspiring part of the project were the relationships that came out of this. And there's a photo of Dr. Troy Lund teaching the lab how to run the test, and we've also equipped them with the supplies to be able to run the test in the future. The hospital faculty and the lab were really excited about it because in the past they haven't known who has G6pd deficiency, and that's very clinically relevant in an area that has so much malaria. I'm going to skip actually to the results because they're really exciting. This hasn't been published yet, but is something that we want to share with you. So not surprisingly, the G6pd prevalence is about 7% for males. That's actually a bit lower than other parts of Africa. But when we looked at the G6pd deficient and non-deficient males, there was a statistically significant relationship between G6pd deficiency, hepatitis C, and syphilis. This has never been described before and raises a lot of interesting questions about the susceptibility of patients with G6pd deficiency to infection, and could even inform ways that we treat and prevent patients with hep C and syphilis. We're going to repeat this in Nigeria in the next year, and be looking forward to that. And then lastly, I would just want to say thank you to the many faculty that have invested in me over the past 4 years. I just took a position at Nationwide Children's at Ohio State, so I will be leaving this fall, but I'm really grateful for the awesome training I've received here and hope to stay in touch.
So we plan to take questions at the end, and so I get to speed us into the introduction of next year's chief. One of the joys of doing global health, so one of the joys of doing pediatrics is you work with kinder people than other fields. Then a subset within that is global health, which are exceptionally kind. And then a subset within that have been our global health chiefs of the year. So from Nate to Steph, and now to Ife, who gets to carry the kindness torch forward. So I will introduce you to Ife Ojo, who is graduating this year, trained in medical school in Nigeria, then worked with the WHO, World Bank, and is now here to tell us about a project he did with Dr. Slusher in his home country.
Thank you, Mike, for that kind introduction. Good morning again, everyone. I am Ife Ojo, and I will be telling you about a formative research piece that I was able to help lead and implement along with the other colleagues mentioned on this slide in Nigeria, which is my home country. In many ways, this international health elective was a dream come true for me because I came to the University of Minnesota because I knew there would be opportunities to do global health work while I'm here. So I am really glad to have been able to do this elective between December 2016 and January of 2017. I'm from Nigeria, and it's a very beautiful and diverse country. It's in Western Africa, and it has a population of 180 million people, of which about 45% of those are under the age of 15 years. It's very big, but it's still about 10% of the United States land mass, even though we have over half of the population of the US in Nigeria. So you see a lot of people in Nigeria. As you might be able to appreciate from these pictures, there's also a lot of inequalities, worse than we see in the United States. The rural-urban divide in Nigeria is very real. And despite these challenges, many of the people in Nigeria are friendly and happy, like me. Bowen University Teaching Hospital was the site of my international health elective. It's a Baptist mission hospital that has been providing care to people in this region for 110 years. And this hospital is heavily dependent on industrial power generating sets for their electricity because there's limited government supplied electricity. Also, they have limited running water, which they use judiciously. The project was based on the filtered sunlight phototherapy work that Dr. Tina Slusher has been leading for the past few years. We all know that neonatal jaundice is prevalent, and about 10% of babies would need some form of treatment for their jaundice. However, the conventional phototherapy units is not readily available in many settings, and where it is available, the irradiance, which is the effective part of the phototherapy that the baby is receiving, is either poor quality or there's no electricity to power these machines. So Dr. Slusher led this randomized control trial of phototherapy using filtered sunlight versus conventional phototherapy in Nigeria, and filtered sunlight phototherapy to be both efficacious and effective in reducing the serum bilirubins of this baby that had mild to moderate jaundice. An ongoing trial on moderate to severe jaundice was what my project was piggybacked upon. A problem with filtered sunlight phototherapy is that babies that are receiving it can either get too hot or too cold because the sunlight is powerful in its rays and the babies are completely exposed. And this was the setting in which we did a study at Bowen University Teaching Hospital. It's a greenhouse type structure, and the babies are placed in open cribs like this, wearing their diapers and eye protection. Thermosports is something that Dr. Slusher came across during a conference where they were talking about its use in preterm low birth weight babies to continuously monitor their temperatures. So we were curious to see if these discs that had been designed mostly for hypothermic babies, as you would see that they have a 3 color changes in the hypothermic range and only one on the febrile side. We wanted to see if this disc would be able to monitor the temperatures for the babies in our study who were receiving filtered sunlight under ambient conditions, and if caregivers would be able to correctly interpret the colors, despite the fact that this was directly under sunlight, or in the case of the babies that were receiving conventional phototherapy, the blue lights were switched off for them to be able to see what color was being shown on thermospots. We also wanted to see if caregivers would be able to identify appropriate action based on the color changes on these discs. So we designed this study very simple to have study nurses check. They had the protocol to always check temperatures every hour with a digital thermometer. So in addition to that, we had them reading the color on the thermospots and asking the caregivers what color they saw and what they felt the appropriate action was based on the color change of thermospots. And if a baby was found to be too hot, or the baby was placed on a wet, cool towel to help them cool down, and this intervention was put in place at a temperature change of 37.5 for most babies. And some babies also had a rechargeable fan, or which could also be powered by solar electricity or solar power to cool them down if they needed it. Also, if a baby was too cold, they would receive kangaroo mother care from. This picture is not from our study because we did a modified kangaroo care in which the baby's back was still exposed to phototherapy, so they could still continue to receive the treatment they needed for their jaundice. So with our study, we found that most of the babies remained within the normothermic range because there were interventions put in place to make sure that they would stay within the standard acceptable temperature. And if a baby was noticed to be getting hot, we would place them on the wet towels, like I mentioned, and have their temperatures checked again within about within 30 minutes to make sure that they were responding appropriately. And if a baby had temperature that continued despite the interventions, then this baby gets a workup for sepsis. But we did not have any such babies during the time I was in Nigeria. We had only one baby who had a temperature below the cutoff for hypothermia. His temperature was 35.7, and there was agreement in the caregiver and the study nurse that thermospots had appropriately turned red for that baby. And the blue-green temperatures, the blue-green observations on thermospots was seen in babies that were around 38 centigrade, which was not surprising to us because thermospots was designed to change temperature or to change color when the temperature of a baby gets to 39 centigrade. So the fact that we were actually able to observe a color change before the cutoff was exciting to us, but it was within that place that there was ambiguity between the caregiver and the study nurse, or in the two sites at which we placed the thermospot, just to make sure we were getting appropriate readings. 6 observations were in the hypothermic range, and for these babies, thermospots appropriately turned blue. All the temperatures that were clearly hypothermic were above 38 centigrade. So with these findings, just with 32 babies, 40 patient days, 216 observations, we felt we could tell that thermospots is able to accurately display temperatures for babies that are receiving phototherapy, and the caregivers were able to see what was going on with their babies because they are there anyway, sitting right next to these babies, and they could help serve as the sensors and the one-to-one nurses that babies get here most times, but are sadly not readily available in my setting. And the other thing is that the thermospot was not showing us a broad range of temperatures in babies because we put things in place to make sure that the babies stayed within the normal temperature ranges. We noticed that the stickiness of thermospot was decreasing after 2 to 3 uses, which was concerning because the disc was something we were hoping to use over and over again. It's just 50 cents a piece, so it's not expensive in the US, but when you convert that to Naira, that's about 150 to 200 Naira, so it's expensive. So we were hoping to keep reusing these discs, but for some reason, the stickiness reduced after 2 to 3 uses. So what we're trying to do now is to work with the manufacturers of thermospots to develop a new version of the temperature monitoring disc that will change color at a defined cutoff at 37.5 centigrade, so that when a baby is beginning to develop fever, it's obvious to everybody. And we're also hoping to work with them to have an additional color change on the hyperthermic side. So basically it works like the light spectrum of the rainbow. It goes from red to blue, unfortunately, so we can't change that. Red is cold, yes, difficult to get. But what the way we explained this to the families was the color on the disc is telling you what to do for your baby. So if it's red, your baby is cold, so you need to warm them up. If it's blue, your baby is hot, so they need to get cooled down. And I felt that was a little bit easier for people to understand. So we are hoping to add violet on the hypothermic side. The other thing I want them to do is to improve the adhesive nature of the disc so that we can get more uses out of it. Another option to get around that is to use clear medical tape on it, and we're also thinking about that. We want to be able to validate this disc in neonates and infants up to 6 months, because so far we're looking at people that are freshly born and have very thin skin, readily accessible vessels, and all of that. But if we are able to see that thermospot works even for babies beyond the neonatal period and or adults, as I would mention later, it might have much more widespread use in nurseries where they have very high patient-to-nurse ratio, and the parents can use this continuous temperature monitoring device because they are right there. The kinds of places we see this disc being able to be utilized is with preterm babies in incubators who unfortunately in some settings have gotten too hot from a malfunction of the machine or from a caregiver or a user error. But if with the thermospot, we're hoping to see the changes early and monitor what's going on. Infants admitted for malnutrition or infectious diseases could also benefit from this, and normal newborns in community settings. So we can determine that a neonate is getting febrile or is developing temperature instability and can go to receive appropriate management, investigations, and workup like we do here. Also, if a mother is too cold in a very cold winter environment, she's not able to provide appropriate kangaroo mother care. And I know that this disc even works in adults, so we're hoping to also test it in older people. So I would like to thank all these organizations that provided funding support for me: the Baptist Medical and Dental Fellowship, Christian Medical and Dental Association, our program here, the Global Pediatric Division, and the American Academy of Pediatrics for making this trip happen. Thank you all so much.
So next we get to go to an entirely different part of the world, and we'll hear a story from Claire McNeil. And what I really like about this is it's an example of a project that shows continuity. So it's going to build off of a project from a previous resident and show how a lot of this work has been longitudinal over the years, and also how really advocacy and servers can fit in this model as well. So with that, Claire.
Good morning. Oh, wrong way. Okay, so I had the opportunity last fall to go to Bolivia, which is one of 2 sites in Latin America in the Global Health Program. I chose this largely because I see myself in the future caring for a diverse patient population that involves Spanish patients, which is something I really enjoy right now at Coop Clinic. Bolivia is a landlocked nation in South America. It's diverse both in its topography, ranging from the Amazon basin all the way to the Andes Mountains, and in its people. There's 4 official languages of the country, one of which is Spanish. It's actually the poorest country in South America and is considered a low middle income country. I was stationed in an area right outside of Cochabamba, which is in the highlands, and the surrounding town was called Tiquipaya. The sponsoring organization that I was a part of was called MAP, and MAP's an international Christian organization that provides medical assistance to those in need. MAP has several facets in Bolivia. One is a Chagas outreach program, one is a primary care clinic, another is called FUBE, or Fundación de Brisa de Esperanza, which provides comprehensive care for victims of sexual assault. And then lastly, they're very involved in infant and child development. And this has been a true passion of the site for quite some time, but it's had a renewed focus in recent years, and particularly this year. There's a center called El Centro Educativo, which is a Montessori-based school for infants all the way to 6-year-olds. And this is one of the centers for this interest in infant development. Well, this school's been present for a long time. The founders of the school, as well as MAP's current directors, who are Dr. Jose Miguel de Angulo and his wife, Luz Stella Lozada, they have an extreme interest in infant development, and they see this as the way to give Bolivia a future. This initially started through research of Jose Miguel and looking at international texts and studies. He's written books specifically designed for Bolivia that describe the neuroscience of development, in particular focusing on the time from conception to day of life 1,000. He also has moved forward from this text and talked about how he thinks this focus on infant and child development can build a new Bolivia that he sees with a brighter future. As part of this, he sees a pilot project starting, with the school being the center place of this. He sees it not only as a pilot project at the school, but also to include home outreach, involving community members and parent groups, and building enthusiasm around this vital time in life. One of his central models that he talks about in this is imagining the brain development of a young infant as that of a tree, with 5 determinants, which are the roots of the tree. Those are building a secure and enriching environment for the infant, physical nutrition, emotional nutrition, cognitive nutrition, and self-efficacy. None of these are really new ideas for most of us sitting here, but he really brings it to life, and I think in a way that a lot of these Bolivian educators can understand. Knowing all this, and knowing that he had the opportunity for residents coming down, hopefully year after year in Bolivia, he was hoping to build on evidence-based research in the United States to kind of work on these 5 determinants of health. One area that was very interesting for him was focus on reading and interactive reading, in particular with caregivers, to work on these determinants. He knew about Reach Out and Read, which has been an extremely successful program in the United States based out of pediatricians' offices and working to give books for free to children, but also teaching parents through practitioners describing ways of interactive learning and using books as a tool for looking at how a child's developing. Knowing that, he asked Matt Kudek, who went down last May, if he would try to launch a program that was based on Reach Out and Read at the school. So Matt, during his time down there, was building on former residents and faculty that had gone. And during his time, one of his projects was forming a program called Programa ABC, or Ayúdame a brotar mi cerebro, which I thought was a sweet title because it means help me to sprout my brain. The idea of the program was, while well child checks aren't common in Bolivia and a good source of having this relationship for literacy, the school was. And so the idea was donating books that would be reused in the school, set in classrooms and brought home by students, and then teaching parents ways to be interactive in their reading at home, something that was natural and normal for some, but kind of foreign for others. During his time there, he created a program model and identity. He purchased books through the generosity of the University of Minnesota Peds department that were donated. And then he also provided some parent education in 2 classrooms. He even sewed these bags, which I was not as good a person as Matt to practice my sewing skills. But the Bolivians found these to be really important for having respect for books, identity, and teaching responsibility of bringing them back. So during my time there, I wanted one of the things I worked on to be building on Matt's project, this Programa ABC. And so I did some pre-travel prep, some study, repeated a needs assessment, increased program capacity somewhat, and then had education opportunities. I also wanted to leave parents with a little bit of education regarding the program and identify future directions for other residents going to Bolivia. First in pre-travel prep, I looked into a company that Matt had used called All About Books that promotes literacy in the United States. And again, through the PEDS department, we were lucky enough to donate 133 books. They're bilingual, sturdy, strong books to Bolivia. They were outfitted with the stickers that Matt had created to encourage kind of the identity and remembering that this is about development and excitement for reading. Then in independent study, I read the text by Jose Miguel. They were often research that I'd read in the United States already, but making it specific to the Bolivian experience I had. I participated in this infant development group, which was new in the few months before I came down there. They had meetings regarding excitement of planning around how could this be a pilot project. They also had their first few parent outreach meetings with community members, building excitement around supporting pregnant women and how to build enthusiasm around infant development. And then lastly, I read from texts regarding infant development and how that fit into the evidence behind Reach Out and Read so that I could explain better why this program made sense. I wanted to know what the parents thought of this, and so I consented those that were willing for an audio recording and a standardized interview regarding what they thought of the experience. And then I transcribed it into Spanish. And I tried to look at it through a qualitative manner. It was really hard to get parents at the time of the school year it was, so that was definitely a learning piece for me. But still, there were themes that emerged that I think were helpful. So they were thrilled that the program encouraged reading. They loved these book bags. They were excited to share how they read at home and stories with their children. They found that the toddlers and babies benefited hugely from this, which wasn't intuitive for some. And then their habits at home varied, and favorite book themes varied too among kids at home. They had some ideas for improvement, so increasing capacity, activity planning around the books. Some wanted to incentivize this, which was interesting. Some would like to learn where to get books like this in Bolivia because most of the books that were sold were more flimsy, they'd fall apart, and they were really commercialized, like based on TVs or movies, and not just on themes about growing up or home life. I also talked with the teachers, and they had similar thoughts and some more specifics as to how to make the program work in each individual classroom, which was really helpful. Then in regards to increasing program capacity, I brought down the books that were donated. With the help of another teacher, went out to the market, which I thought was like a block away, and it turned out to be the largest market in South America. And we bought material for the bags, and some generous parents and teachers volunteered to sew them. And then I think one of the more helpful things was having a discussion about the evidence behind this with the teachers. And they were pairing psychologists actually with teachers at the school for this infant development pilot. And so we talked about why the program existed in a standardized PowerPoint form that could be edited for future residents to use. They loved hearing about the evidence behind Reach Out and Read and wanted to know where they could get their hands on Spanish journal documents, which unfortunately I was unable to find. But there were awesome resources through Reach Out and Read or Leyendo Juntos for Spanish speakers in the United States that they were excited to see. Some were tools that focused on different stages of development and how you can involve reading at an appropriate level for children. Others were building excitement like prescriptions around Reach Out and Read. And then finally, I wanted to provide the parents with a handout for home. So explaining what the program was, but also how could they do this at home. So giving kind of tips that Reach Out and Read provides for how to read at home with their family on a practical basis. Again, parent meetings were attempted, but given the time of year with school ending, I think it'd be go over better during another point in the school year. There were definite opportunities for growth and stability, I think. These are some of the kindergartners that were excited about the books. So one area actually speaks to this picture, thinking about how to provide a source of books. So I think incorporating books that are already part of the library but not used at all would be wonderful. Having books that focus on Bolivian themes, which are really difficult to find, so being somewhat resourceful and thinking about that. Making sure the books come from the Bolivian school and teachers and aren't delivered by us as U.S. partners, because I got myself into some awkward situations with that I wouldn't want another resident to have to repeat. Whoops. Oh. And then the few other things I think revolve around sustainability. So that's not only the books and the bags, but it's also increasing education, because Jose Miguel is a big thinker, and he sees this as a pilot for a piece of this infant development, and he'd love to create something that can be evaluated, perhaps through methods similar to those used for reach out and read evaluation, and replicated across Bolivia. And so while it's a small project to start out with, I think the fact that we have evidence in the United States that a program like this makes a difference in the life of kids and their development was really exciting. Oops. And then I just want to thank the Department of Pediatrics, the Bolivian partners, especially Jose Miguel and Stella Luz, and then the educators who were very gracious at the Educational Center, global health faculty, especially Kate Shafto, who's the lead for Bolivia, and then Matt for his work down there before I came. So thank you.
Our last presenter this morning is another example of longitudinality, but his own. So this is actually about a project that was an interest that got brewed during his time in medical school and was able to continue it through residency. And we've been excited as a department to be able to support him with that. So with that, I'll introduce Dr. David Mills, who will share some of his work in Gaza.
All right, let's see here. All right. Good morning. My name is David Mills. I'm one of the third-year pediatrics residents here. So for me, this global health project is kind of a culmination of a number of my personal interests. During my undergraduate education, I developed a strong interest in the Middle East, in its history, culture, and politics. I wanted to gain a first-hand experience living and working in the region while also pursuing a medical degree with a strong global health focus. Thus, I decided to attend medical school in the south of Israel. During medical school, I spent extra time exploring issues related to social determinants of health and their effects on indigenous populations in Israel and the occupied Palestinian territory, which is comprised of the West Bank and Gaza. I'll also refer to it as Palestine. So building off those experiences and committed to working in Palestine in the future, I wanted to undertake a project that would help me understand the challenges to receiving care in Palestine, to learn to conduct clinical research in a global health setting, and ultimately develop and foster relationships that may lead to future collaborative work. Preparation for my project actually started at the beginning of my intern year in the summer of 2014. I conducted my field research in the spring of 2016, which is about a year and a half after initial project preparation. So to really understand the context in which pediatric cancer patients are treated in Gaza, and to kind of understand my project in general, I want to spend quite a bit of time, a little bit of time, discussing Gaza's unique position in the world and the challenges it faces. So the Gaza Strip is located on the eastern Mediterranean Sea, bordering Israel and Egypt. The Strip is 139 square miles, which is roughly the equivalent square mileage of the city of Detroit. Gaza holds a population of 2 million people. 70% of that population hold refugee status. Gaza has the 30th fastest population growth rate in the world, despite its small size. And 51% of the population is 18 and under, which is an extremely high percentage, which is, in comparison, the U.S. has an under 18 population of 22%. Gaza is considered a low middle income economy with one of the highest unemployment rates in the world at 43% and a very high poverty rate. Currently, Gaza is under an air, land, and sea blockade that was enacted in 2007 by Israel and Egypt, which has kind of effectively isolated the Strip from the outside world. There's only 2 foot crossings into the Strip, one from Egypt in the south and one from Israel to the north. Both have strict exit and entry requirements. A 2015 report by the UN actually noted that given the disturbing economic trends in Gaza, including destruction of infrastructure from recurrent wars, an economic blockade, and severe restrictions of freedom of movement, and de-development of the Strip, which is not only halting of development, but reversal of development, the Gaza Strip may become uninhabitable by 2020. To give a little perspective on the restriction of movement experienced by the population in Gaza, we can look at some statistics from 2016. From a medical perspective, less than 50% of medical referrals were approved by the Israeli military to travel through Israel's Erez crossing for treatment outside of Gaza. The Egyptian crossing was open only 48 days, allowing a limited number of individuals who fit a narrow criteria permission to travel. This is a photo inside of Gaza near the Israel border. Once you cross the Palestinian checkpoint due to security implementations, civilians and patients and our pediatric patients have to walk over a kilometer in this cage-in walkway through a no man's land to reach the crossing, which is basically a building equivalent to a large security checkpoint and passport terminal. From a clinical perspective, I particularly chose to study ALL in Gaza, as we know that ALL is the most common childhood cancer and can be treated with very good outcomes at a relatively inexpensive cost. However, 80% of children with ALL live in resource-limited countries where the layers of complexity to receiving care, especially in settings like Gaza, have significant effects on outcomes. We also know that in order to achieve these high survival rates, intensive supportive care and long-term treatment and follow-up is needed. Thus, a multidisciplinary approach is a foundation of excellent ALL care. This includes a team of pediatric primary and subspecialty physicians such as pediatric oncologists and oncology surgeons, skilled nursing, social work, child life, treatment modalities such as chemotherapy and radiation therapy, and lab diagnostic and monitoring capabilities. The ability to access these resources and the majority of these services are either not available in Gaza or fluctuate frequently. Thus, given my interest in studying barriers to care in ALL in Gaza, the aim of my project was twofold. I wanted to understand what barriers may affect our ability to provide care for our pediatric patients and also understand how these barriers may affect ALL treatment outcomes. So my project was retrospective in nature. The first issue was identifying charts for review. To do this, I went through a handwritten log of cancer cases kept by a senior oncologist that had tracked every new cancer diagnosis over the past 10 years. This list was cross-referenced with an electronic record database that also held some patient demographic data and ICD codes. All of the charts with ICD codes identified as ALL were pulled and hand-reviewed and cross-referenced with the handwritten log. Overall, 131 charts were identified in the process. After initial review, 13 patient charts were unable to be located and 34 charts were identified as diagnoses other than ALL. 84 patients met our inclusion criteria, which were the following: admission to the pediatric specialized hospital in Gaza between 2010 and 2015, less than 12 years of age, and diagnosis by ALL diagnosis by bone marrow evaluation. As for results, it's important to note that in Gaza, pediatric patients are defined as birth to under 12 years of age. Otherwise, patient characteristics were similar to those seen around the world. All of our patients received standard international chemotherapy regimens. Our risk stratification was based on the BFM International Protocol and St. Jude's ALL Protocol. Main criteria in risk stratification include age and white blood cell count at time of diagnosis and early treatment response and some genetic markers. Overall survival was defined as percentage of patients living 1 in 3 years from initial diagnosis. Event-free survival was defined as percentage of patients free of induction failure, relapse, or death 1 in 3 years from initial diagnosis. When looking at survival data, overall and event-free survival were fairly high. When event-free survival was stratified by risk, however, we see that our patients do much poorer with a 3-year survival at less than 23%. Given our concerns for access to care and resource shortages, we wanted to understand if and where our patients were referred for treatment. What we found is that 100% of our patients required referrals to international hospitals, which I define as hospitals outside of the Gaza Strip, for a definitive ALL diagnosis by flow cytometry and immunophenotyping, and also complete induction therapy. Our patients needed to receive permits to cross the border and travel several hours to children's hospitals in several locations, including locations in Israel, mostly in Tel Aviv, hospitals in Jerusalem, and also West Bank hospitals in Bethlehem and Nablus. In the past, several patients were treated in Egypt and in Jordan. 52% of those patients required a second referral for a handful of reasons, including chemotherapy shortages, methotrexate blood level monitoring kit shortages, induction failure, which required further intensive treatment, and relapse treatment, all of which were not available in Gaza. There are multiple barriers to care that impede access to timely and comprehensive treatment, including inconsistent access to chemotherapy medications, lack of supportive and intensive care, and limited freedom of movement that results in delays in treatment. Just to give you an idea of the current situation in Gaza, this last month, 450 referrals were made for adults and children to receive care abroad. 70% of those referrals were due to drug shortages. There are several consequences of dependence on international referrals to treat our patients. There are delays in treatment. The referral process requires several steps, starting from an official recommendation from a pediatric oncologist in Gaza and approved by an internal referral board. Then a security clearance is requested from the Israeli military to travel through the Israel crossing. Medical companions to sick children, due to strict security requirements, must be over the age of 55 and female. Thus, for example, parents of children with newly diagnosed cancer are unable to travel with their children for treatment. Finally, a bed request is made at a hospital in Israel or the West Bank. This process is tedious and can take anywhere from several days to a month to complete. Our patients and their family member or medical companion may need to be abroad for extended periods of time, which places a particular burden on separated families. Finally, these referrals are costly. At least 40% of the Palestinian Ministry of Health budget is spent on international referrals for treatments unavailable through the Ministry of Health system. From a clinical perspective, overall and event-free survival outcomes are very high. These findings are likely inflated by several factors. Our study excludes patients diagnosed between ages of 12 and 18, which are by definition from our risk stratification high-risk patients. Also, our study excludes most patients who turned 12 during the study as they were transitioned to adult care, and most of those charts I was unable to account for. There are also charts of deceased patients that I was unable to find. Furthermore, 3-year follow-up is relatively short for pre-B-cell ALL, thus a longer follow-up period may also affect our outcomes. When event-free survival is stratified by risk, our high-risk patients have very poor outcomes, even poorer than those seen in many other limited resource settings. We think there's probably several factors to this. This could be due to poor prognostic cytogenetics, which we haven't looked at yet. Delays in treatment may play a greater role in outcomes in high-risk patients, disproportionately affecting their rates of relapse and induction failure. I work with an NGO called the Palestine Children's Relief Fund that is devoted to addressing these barriers to care. This is a computer rendering of the new cancer center that's currently being built in Gaza. Through an NGO Ministry of Health partnership, there are several initiatives currently underway to address resource distribution, to decrease or eliminate the fluctuation of medications and medical supplies, investment in health infrastructure, including a new cancer department, and educational initiatives for nurses, physicians, and staff that is integral in developing the multidisciplinary approach needed to provide the best care for these patients. The ultimate goal will be to decrease or eliminate the need for international hospital referrals. Here's a picture of the new cancer ward currently being built. I plan to continue working on this project in the upcoming year and into the future. Other questions that I think would be interesting to answer include investigating the correlation between length of delay in treatment and its effects on outcomes, expanding this project to include patients 12 to 18 years of age, or expanding the project to even include other types of childhood cancer. I want to thank everyone who's been involved in this project, especially my senior mentor, Dr. Zina Salman, who's pictured to the right here. Thank you to all of the pediatric oncology, my colleagues in Gaza who have helped work on this project, and Steve Soseby and Suhail Fleifel of the Palestine Children's Relief Fund, and finally my global pediatrics mentors for the past 3 years, Dr. Mike Pitt, Dr. Cindy Howard, and Dr. Tina Slusher. Thank you.
So if you can see our faces in the front, I mean, just beaming with pride for the work that these residents have been doing in global health, and really showing that global health electives are not vacations. And one of the things we're proud of, so in this month's pediatrics, I wrote a paper with several colleagues on supporting global health at the department level. And really want to thank Joe and the department for us being the program in the country, if not the world, for global health education for pediatric residents by having the only division of global pediatrics and allowing this type of work to go on. So with that, I will say thank you on our behalf, and then I'd like to open the floor for 5 minutes of questions for our presenters.
Some of the parents did talk about not being able to read. It was rare, but some parents. Also, sometimes the language spoken at home was Quechua or not Spanish. But we focused on, just as we would in the U.S., focusing on pictures and interaction, and that if you didn't read, it was still super helpful to your kid, interaction. Yeah.
Amount of induction failure in your high-risk patients. And that might be a place to look for interventions, because even a high-risk kid on a 3-drug induction usually succeeds, and you were down at 60%. So,
yeah, and one of the kind of follow-up projects and things that we're going to look into is thinking about what the causes for those high induction failure is. But thank you. Thank you.
I have a question for Ife. So you had newborns with hyperbilirubinemia, and then you had 6 or 9 of them develop temperatures. Did any of those kids get worked up for infection? Were you worried about infection with that? Certainly hyperbilirubinemia is a risk factor for it.
Yeah, thank you for that question. We would have worked them up for infection if their temperature did not come down within 30 minutes. But for all of them, their temperatures resolved, and so we were not concerned about a temperature instability or beginning of sepsis in those babies, because we knew they were in the greenhouse, basically. They were getting a lot of heat from the sun. And so once we adjusted their thermal environment, if they responded, we did not work them up. But the protocol was to work up any baby that persisted in the hyperthermic range after 30 minutes of changing what's going on.
Ife, I'm just curious why you used eye protection for the infants.
I think Dr. Slusher should answer that question.
We wouldn't have gotten it through any IRB if we hadn't, since that's standard for phototherapy in the U.S. Yeah, right. We debated that, and we weren't terribly strict if the mothers took them off at times during the therapy, but it was standard of care, and we needed it for IRB. We actually did use cut-off sock tops, so they were pretty cheap eye protection.
Well, thank you guys for spending the morning with us. Thanks to our presenters. I'm going to have us say thank you the way that we do in Tanzania. So in Tanzania, when you say thank you, you rub your hands together like this, and then you clap and say the word Pasha, and you say that 10 times if they were really good. So we'll do it for you. Ready? 1, 2, 3. Pasha, 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 Pasha.